Dr. Southard received his bachelor's from the University of California, Davis. He later went on to do his medicine and internal medicine training at Georgetown University, and then returned to Davis, where he did his cardiology, interventional, and structural cardiology fellowship. He holds a very dear place to a lot of us because he still comes up here a couple times a month, so we try not to let him go. He's currently a professor of medicine at the University of California, Davis. He's the director of the cardiac cath lab at UC Davis, as well as being the director of the transcatheter aortic valve replacement program, both at UC Davis and here at Shasta Regional Medical Center. He's published numerous articles, been part of numerous NIH as well as industry-sponsored trials, and he's here today to talk to us about evaluation of valvular heart disease.
Well, thank you so much for having me. Back again, every couple of years we have to talk about some valvular heart disease, mainly because we're still not doing a very good job treating patients, picking them up, getting them treated, fast enough. To follow up on the last talk, we're lucky enough, I have nothing to do with this, but have a photon counting CT scan at UC Davis, and it has absolutely changed the way in which you can evaluate patients for flow and coronaries and things like that. So, and if my wife was here for their first nutrition talk, it would have been even better because, healthy kitchens, healthy lives, and nutrients are very important. So if you don't do a lot of that stuff, you end up with valvular heart disease. And that's what we're going to talk about here. It's kind of the evaluation and treatment. I do trials related to valve replacement strategies and things like that for my only disclosures. But it would be remiss of me if I didn't at least pause for 1 second. I know there's other cardiologists and people in the room that have worked with and published with Dr. Brunwald, who you'll hear from even after me. But Dr. Brunwald is considered probably one of the fathers of cardiology, and he passed away April 22nd of this year at 96 years old. He, in 1963, this is he and his wife, who I'll also speak about for a second, has done, if we just talked about one thing that he did, would define a career today. And he really wanted to be an engineer, and through the encouragement of his mom, decided to become a cardiologist, and went to medical school in the early 50s and met his wife, Dr. Nina Starr. So before I go with him, his wife, Dr. Nina Starr, didn't really hyphenate names back then, or she would have been Starr Brunwald. So she changed her name to Brunwald. She was the first general surgeon at Bellevue Hospital in New York. She was the first female general surgeon. She was the first ever female thoracic surgeon certified by the Society of Thoracic Surgery. She was a heart surgeon amongst a room of only men at that time, not only holding her own, coming up with some of the first ever implanted mitral valves in patients that bore her name, and a valve that she created was put in patients in the 60s to 70s, right? And there's a great legacy with Harvard, as they eventually had 3 daughters together. And then Dr. Brunwald, he went on to do so many things, right? Being at that point, the Peter Bent Brigham, now Brigham and Women's, right, was chief of medicine for 24 years. He was in San Diego. He was at other centers before that, really looking at patients with valvular heart disease, hypertrophic cardiomyopathy, starting to TIMI trials and collaborations, and looking differently at how we treat patients with heart attacks, and working with patients with heart failure and ACE inhibitor and aspirin therapies, and everything that he had done in his career. Really, the things that we do today started with a lot of these people. So I just wanted to take one time to say he did pass in April, but I think his legacy and the things that he did to change cardiology are insurmountable and just unbelievable. So, and his wife was as important to what we do today. So what a power couple. I think there were high expectations for their daughters, but I'll just leave that right there. So some of the things that I show you about how we look at the natural history of patients with aortic valve disease really stemmed from those patients who had rheumatic fever and rheumatic heart disease. But we'll get to this coming up. So there's lots of different things that we can do for valvular heart disease, right? In the aortic, mitral, tricuspid, and pulmonic positions. So just know that we should start with medical therapy, but if we back up before that, we should start with the examination, the evaluation, and the early treatment of patients with valvular heart disease, which always starts with medications. And then when those medications are not doing the job or the valve disease becomes severe enough, we have both transcatheter and surgical options. And I'm not going to go over everything for every valve, but I'll show you a few things and some of the newer things that are out there and newer things that are coming shortly. So if we start with the normal function, really the function of these valves, right, is really just to maintain forward flow and prevent regurgitant flow, right? It's just making sure things go in the proper direction, and they have to all work together, right, because they're all working at the same time. So whether you open properly or close properly makes a difference. And we follow these things throughout the cardiac cycle, and treatment of patients with valvular heart disease has changed over the years, and the identification of valvular heart disease has gotten better. But we also see that when there's something that you can do for a patient that tends to be less invasive, we tend to pay more attention to it. We've ignored the tricuspid valve for many years, right? And now there's therapies for it, so people pay a lot more attention to it now, or at least we should. So we know that the valves can become stenotic, regurgitant, or both. Both can encompass that valve itself. So the combination of these valves, if they're both stenotic and regurgitant, and if you have more than one, then your engine or the heart will not function properly, and patients get progressively more short of breath or have more symptoms, right? So when we think about the aortic valve, it can be both stenotic or regurgitant, and we'll talk a little bit about both. So the most common reason that you could have aortic valve stenosis in the United States is what we call calcific degenerative aortic stenosis. As we get older, as there's inflammation, as we get breakdown of the valve, we end up with cells getting inside the leaflets themselves. They end up creating calcium and causing that valve not to open very well. And we do see patients with rheumatic disease, patients born with bicuspid valves, and then patients can have aortic insufficiency as well, both acute and chronic. The valves can leak. It's either a problem with the valve itself or the aorta itself. That can be dilated or Marfan's or bicuspid rheumatic disease that can cause problems to these valves. The vast majority of patients who develop valve disease in any of the four positions, it's not acute. Yes, you can have tears in the aorta that cause wide open aortic regurgitation. Yes, you can have an acute infection that develops or endocarditis that causes that valve to go bad. But the majority of patients, this is a process that takes place over many, many years to decades before you actually need or identify patients with these type of valvular lesions. Luckily, the evaluation for these patients is usually ultrasound or echosonography, echocardiograms, so that it's non-radiation based. But you can look at what we're dealing with in there, and right, the surgeons get to look at this when they operate. Looking at patients with rheumatic or bicuspid or degenerative valves, they're all different. And the thought of how do we prevent this from happening, how do we prevent the calcification from starting, is probably more important upfront for the long term to be able to prevent this from happening than trying to deal with it once it does, right? And we're still trying to figure out what that means and how do we actually prevent some of these calcific or degenerative processes from happening. But we know that we're seeing it more and more, and partly because patients are living longer, partly because we do know a lot more about medication and nutrition and exercise, and smoking is certainly less now in certain states than it was before, and patients are living longer. So the number of patients that we're going to run into these valvular heart disease continues to grow, and the population continues to age. So if you look at the overall life expectancy, it started to come down after COVID, and it hasn't quite turned around yet. We're still not living as long as we did 5 or 7 years ago. But we do have treatments for these things. And if we think about the pathophysiology of just aortic stenosis itself, in the upper picture, you've got a catheter in the left ventricle, and we've got a catheter in the aorta. And when that valve opens, the pressure should be about the same. There's no resistance to flow. And the one down below, we've got the higher pressures in the left ventricle and the lower pressures of the aorta. And when that valve doesn't open well, we build up pressure inside the ventricle to force open that stenotic valve. And though your cuff pressure might say 120 when you check it in the arm, it might be 180 or 200 or so inside the left ventricle every time the heart beats. And you can imagine that leads to deleterious effects. The muscle gets more hypertrophied. It can lead to diastolic dysfunction. It can lead to mitral regurgitation that can eventually affect the right side of the heart as well from a single aortic valve lesion. So when patients, their blood pressure is 120, they say, I can't really walk around very well. I do good at rest, but when I try and do more things, I really can't do it. It's because the pressure's already 200 in their heart at rest, and it goes up much more when they try to walk around. We usually define a lot of these valve disease or stenotic valve disease based on what the area is. And we'll show you what it looks like in the aortic position as well. So the natural history is a slow progression of calcification, inflammation, and stenosis. And then eventually you will get to the point, if you live long enough, that the valve will become severely stenotic, and you will likely have symptoms if you don't die first because of it. And that's the true statement, which I'll show you, that as we follow patients over time, the number of patients with moderate or severe aortic valve stenosis who go undiagnosed or untreated and they die from the disease is real. And I was just talking to Oz before this, right? He got a call even yesterday. We see patients all the time of, hey, Mr. So-and-so is going to go have this surgery, and they came in and the anesthesiologist says they're in heart failure and the patient has severe aortic valve stenosis that's undiagnosed, and they made it all the way to the pre-op area before you get a phone call. So we need to, I always tell people, listen with the intent to hear. Your patients are coming into the office. Listen, pick up something new, get an ultrasound, and help save their lives. So we know the older you are and the more risk factors you have, specifically chronic renal disease, we have a problem with both calcium and phosphorus handling, and that can lead to progressive aortic valve stenosis. We don't really have medications to date proven to slow the progression. We've tried statins, we've tried other things. Once this process is severe enough, we can't reverse it yet, but there are things that we're still looking at. We try and lower blood pressure with ACE inhibitors, ARBs, maybe beta blockers and hydrochlorothiazide, but we'll talk about that, but definitely ACE and ARBs. Statins to try and reduce the overall cardiovascular risk, but don't slow the progression. We've tried that, and those trials are well published. They are looking at lipoprotein a, and there's an ongoing trial looking at lowering lipoprotein a for your overall cardiovascular health and fitness, but a specific subset of those patients, they're trying to treat aortic valve stenosis or start early and try and lower lipoprotein a. There is some literature to suggest that the higher your lipoprotein a levels are, is associated with progressive aortic valve stenosis. So we're looking at all these other things you heard about, colchicine and PCSK9 inhibitors. There's lots of different things and medications we're trying to use to figure out if we can slow the progression of the disease. We can imagine that once it's very calcified and those leaflets are that stiff, we're really not going to be able to prevent it at that point. So we'll have to start earlier. We use echo, remember. We look at valve areas. We look at how fast the blood is going through the valve. Does the valve opening well or not? And I try and, as practitioners, I would tell you that anytime if you see an aortic valve area that's 1.5 or less, just start getting those patients over to see a cardiologist, right? So when we see moderate mitral regurgitation, moderate tricuspid regurgitation, just get those patients in to see cardiology. Let them start following those patients along for you and help determine when that patient might need to have their valve replaced. So the echo is the key, and from the aortic valve, I say if you have a valve area less than 1.5, start seeing someone, and certainly if you have a valve area less than 1, you're already at that severe aortic valve stenosis. This is Dr. Brunwald's and Ross's publication from the late 60s looking at patients that had rheumatic fever and rheumatic-associated heart disease. The curves are shifted to the right for patients with calcific degenerative, but we do know that when you start to have symptoms, you better do something about it. And you can present with angina, syncope, which is falling over, or heart failure. And if we wait for these patients to have these events, we already know we've probably missed the boat. And we have some data to suggest that. And there'll be new guidelines for the treatment of patients with valvular heart disease at the end of this year, and if not, first quarter 2027. And those guidelines are going to change the way we practice the treatment of patients with valvular heart disease. So we know that there's a lot of gaps in the diagnosis of patients with severe symptomatic aortic valve stenosis. Doing nothing about it is no longer acceptable. They don't have to have surgery. There's minimally invasive ways to treat these patients. And if you look at how patients do from cardiologists that get patients their valves to cardiologists who don't get their patients their valves, there's an increased risk of death. By just watchful waiting of patients with valvular heart disease, without a referral to someone who might be able to treat it, patients die while waiting. So there's a price to be paid for not getting these patients treated in as fast a manner as you can. So there's disparities as well. We know between women and heart disease or those that are non-white and heart disease, and those disparities are real. And sometimes there's a distrust, bless you, of the patients with, yeah, we're ready, that's all right. You might need an echo. So there's patients that don't trust their providers, right? So there's all these things we need to overcome, right, to try and get patients treatment of disease. So what do we do with asymptomatic, right? This article was out a few years ago in 2020, but I'm going to tell you we have more data in the treatment of patients with asymptomatic aortic valve disease upcoming. The previous guidelines are based on surgical-only options, right? When Dr. Brunwald was putting together his article in the 60s, heart surgery was just beginning, and it was not benign. They had to wait for patients to really have symptoms so that the risk of surgery was not far greater than just watchful waiting. Now that we can do a lot of other things now and patients do very well, we should be treating patients earlier. So figuring out who's got the disease, right? Here's the malignant natural history of patients with aortic valve disease. Don't do anything is the blue curve at the bottom. This is survival. So you're less likely to survive even at 2 or 4 years if we do nothing as opposed to just replacing your valve. And this is just surgical data. And we have the data for transcatheter valves as well. So watchful waiting is not gonna work. This will be used in part of the new guidelines, I'm sure. We know that if we look at patients at different stages of the heart in relation to aortic valve stenosis, the earlier we get you to some sort of therapy, the better you do. As we go along to the heart is doing great and you just have aortic stenosis, to all the way to the right that we've have right-sided disease. Now the right ventricle is affected. The mitral valve gets affected, pulmonary hypertension, the right side gets affected, and then we decide we're going to send you to surgery. You don't do as well. So getting patients earlier before we have chronic damage done to the heart makes a difference. And we've proved it. And the guidelines are absolutely going to change. I'm sure of it. So we were part of the early TAVR trial, which looked at patients over the age of 65 who had severe aortic valve stenosis without symptoms. And if those patients could exercise, which was over 90% of them, we put them on a treadmill to prove that they could exercise, right? They didn't have chest pain. They didn't drop their EKG changes or anything. And how did they do? And if they were asymptomatic, we randomized them. Half of them got a transcatheter valve with the Edwards valve up front, and the other half we watched. And we watched these patients for up to 5 years, or to when they begin to have symptoms. And that we found, and we don't have everyone past 5 years, but we have a lot, and the publications would suggest that at this point, at a short term, the death and stroke rates and repeat hospitalization were all followed. Mortality was about the same. Watchful waiting, those patients had more strokes up front, more repeat hospitalizations. And when they did come into the hospital, we saw that their EF were down, they had heart failure, and they had developed worsening symptoms that if we had just taken care of them up front, despite the fact that 90% of them were asymptomatic on a treadmill. So this kind of changed the way we think about it, right? We changed the way, and the FDA now has approved the treatment of patients with severe asymptomatic aortic valve stenosis. I feel like I should say bless you, and you're all right too there. I don't want to leave you out, yeah. I mean, Sabina runs my life too, Mo. I mean, I gotta watch this. So we're now gonna be able to treat, and I am certain that the guidelines are gonna change to allow us to treat patients with asymptomatic severe valve disease, not only in the aortic position, the mitral position, and other positions as well, because of a lot of this data. And I also think it's important, though we get nervous to do this, in patients who say, Doc, I'm doing great, I'm doing fabulous, just try and put them on a low-level treadmill, and how do they do? Because you get surprised. And a lot of the patients, my younger patients who have gone for surgical valve replacement, are not asymptomatic, right? This is a young patient, her baseline EKG, she's got left ventricular hypertrophy, and just a few minutes into the treadmill, right, we can focus in, and I'll zoom in, right, there's really marked EKG changes, right? And you might say, oh, it's LVH and things like that, but if you look at it, there's diffuse ST segment changes, and even if you say, okay, just stop, we have ST elevation and AVR, this is a lot, just stop. 10 minutes later, the STs are still down, right? There's so much hypertrophy, there's subendocardial ischemia, there's other things that, is the heart really asymptomatic? And even though this patient thinks they're doing well, they're just not. And there's not. And people are scared and they're nervous. If we tell them, hey, you need to have your valve replaced, no one wants to have heart surgery. I get that. But there's other ways to try and help replace the valves, and sometimes surgery is the right option. So We know that all patients with valvular heart disease should be seen at centers that have options for patients to be treated, right? Both surgically and minimally invasively. Just to remind you, this is the Edwards valve. This is how we place it. We come in from the leg, and we actually pace the heart to decrease cardiac output and let the blood pressure go down. And then we can expand the balloon underneath the frame itself. We push the old valve out of the way, and then the new valve starts working right away. And this is an older image with a TEE probe up top, but now it's done with conscious sedation. We can actually pace off the wire in the left ventricle now. So there's times you can do cases in 20 or 25 minutes, right? With a single LV pacing wire, especially in a bioprosthetic valve, single access, pace, put the valve in, and move on. The team here in Shasta is very efficient and very good, and the complication rates are excessively low. And it goes along with everyone that's here, with some of our anesthesia team here as well. And that's as important as anything else, is having people really everyone working together to really make sure that this happens safely for patients. Cath lab staff, turnover, everybody. There are some things that we still need to know about this. It's the lifetime management of these particular patients. They're getting younger and younger and younger. And we don't have as much data in younger patients, or as much data in bicuspid patients, or how long will the valves actually last, right? We have about 7-8-year data now for a lot of the transcatheter valves, and some 10-year data outside the US to suggest that they're lasting as long as surgical valves, or maybe longer. So that'll be the key, is will they last as long or longer as the surgical valves? Our low-risk trials are about 7 or 8 years out, and we're following patients to see how they do, but we think the transcatheter valves are going to be good. The challenges today are really we treat too late. We should still follow patients with moderate aortic valve stenosis, and trying to touch base with patients about who might get a transcatheter valve versus a surgical valve up front is an ongoing discussion. So here's the team here. Azib Khan and Jessica's in the back. She likes to hide over there, but she's over there. I'll point her out. She just got back from probably a 14-mile jog. She exercises all the time now, so we're going to watch her. But these, I mean, without at least these two up front, Azib Khan and Jessica, this program does not run. I can tell you that right now. So this is well beyond just me coming up to help out. It is a program run in my absence for sure, and it is done very well. I can tell you that, very well. So a little bit about aortic regurgitation, right? And this is now going to start, if we don't have minimally invasive ways to treat things, we try to ignore things, right? I guarantee you over the next year or two, as we start looking at echoes, we're going to find so many more patients with aortic regurgitation. Why? Because we now have a valve that we can put in percutaneously to try and treat it, right? These patients, unlike the aortic stenosis patients who get left ventricular hypertrophy and a very stiff ventricle, these patients dilate their left ventricle over time to deal with that volume overload state. So the valve is leaking in diastole, more blood comes back to the ventricle, it has to squeeze that out, plus all the blood it got from the mitral that comes in, and the only way you decrease wall stress is to dilate, right? And we prefer these patients not dilate over time, but they do. In patients who have aortic dissection or have endocarditis that get acute aortic regurgitation, and I think we're going to have to call it aortic regurgitation. If we call it AI or aortic insufficiency, the minute you say AI, nobody thinks about the aortic valve. So I think we're going to have to call it aortic regurgitation and not AI. It'll be something different. But if the ventricle doesn't have time to dilate, the heart can't deal with it. If you develop acute aortic regurgitation, you go into heart failure and shock. Everything builds back up into the lungs. You can't breathe. Something has to be done right now. Luckily, most of these are not acute. So broad range of presentations. There's lots of things to go with it, with previous either aortic disease or aortic valve disease, lots of things that can cause aortic regurgitation. It is a slow progressive disease with a natural history which is very favorable, and just because you have 2+ aortic regurgitation does not mean in 10 years you're going to have 4+. If you have mild aortic stenosis now, in 10 years, I already assure you, you're past severe aortic valve stenosis. So aortic regurgitation is different. We also don't do a very good job at figuring out who has aortic insufficiency. And there's recent papers and guidelines out that will suggest, now this is even harder to figure out, that MRI is a better study to do. By getting a cardiac MRI, is not done in many places, right? In big centers that have it. It is time consuming, but is the best way to try and define patients with aortic regurgitation. And we're finding out that basing aortic regurgitation based on an MRI compared to echo is way more favorable for the patient. we usually find that they have more aortic regurgitation and patients should be treated sooner. But we have to do some better things here, right? We can try and use ACE inhibitors, ARBs, ARNIs. Remember, you have this wide pulse pressure because all this volume is coming out. They have very high systolic pressures and then very low diastolic pressures, so very wide pulse pressure. And sometimes treating the blood pressure is very hard because it's volume-based, right? So here's aortic regurgitation based on like how big your ventricle is. If we let your ventricle dilate and then think we're going to do something about it, you do worse over time. But our current guidelines suggest wait till the ventricle gets really big and then do something about it. Doesn't make a whole lot of sense if we can prevent it from happening in the first place. But again, valve durability and the safety of the procedure you need to do to treat that valve has to be relatively low risk. If you can take care of the problem up front with a durable valve and low risk to the patient, why would we wait? We shouldn't. And I think some of our guidelines are going to back that up as well. So who goes to surgery? Well, patients with, at this point, severe, I put AI on there, right? AI, severe AI, and symptoms. Even mild symptoms should prompt something. And again, if you have patients with 2 or 3 plus leaks of their valves, have someone see them because sometimes their shortness of breath, dyspnea, and exertion may be due to that valve disease, right? We can put patients on a treadmill. We can see how they do as well, low-level treadmills to see how they do. Surgery is indicated if the squeeze of your heart starts to go down even a little bit. If you're going to go and have bypass surgery and you already have moderate or maybe greater aortic insufficiency, aortic regurgitation, it should be taken care of. But again, our guidelines are based on letting that ventricle dilate either in systole and diastole before we do something about it. And they're likely going to change, I think, coming up this year. So we have newer valves. The valve on the left, called the Jenna valve, is now FDA approved for the treatment of patients with aortic regurgitation. It is a percutaneously or endovascularly placed valve that goes through a transfemoral sheath. And the valve on the right, which used to be the JC Medical, now Edwards has this technology, the J valve, and they are in the middle of what we call the Journey trial, treating patients with severe aortic regurgitation by endovascular means. So we know that if we wait for patients to have symptoms and then do something about it or do nothing about it, their mortality goes up substantially, right? So if you wait for someone to have class 3 or 4 heart failure symptoms and then do nothing about it, their chances of surviving a few years is abysmal. So we'll now start looking at patients with aortic regurgitation in a different light because we can do something about it. Different than the previous valves that we have, this valve actually has these little grippers. It's like a little moon landing device. It comes in, goes into the sinuses, grabs onto the leaflets. So it has a nice solid hold in there, and then we deploy the valve. Okay? Unlike aortic stenosis, where you use the calcification of the annulus, the calcification of the leaflets to hold the valve in place, this now has its own anchoring device that we can use to keep this valve in place. So this valve is now out there, and will be used, you'll see, more and more frequently for patients up front that don't really have great surgical options. With pretty good, these are the high-risk patients that kind of went through some of the trials with low mortality at a couple of years, and now they know how to use the valve even better at this point. Hemodynamic performance is great, big valve areas, low gradients, the valves stay where they are. And once you learn about the depth of where you place the valve, the risk of pacemakers has gone down substantially. But a very effective valve here with some at least multi-year follow-up so far. So that's now coming. So this is the Edwards Journey pivotal trial, which is ongoing. They have a valve as well that can treat probably a larger array of patients with big annuli in a non-surgical way. I'll show you just a few things from my colleague, Dr. Singh, and his group that do things on the mitral and tricuspid. You'll see more mitral regurgitation than you see mitral stenosis in your patients. The treatment of mitral regurgitation is through treatment of blood pressure and diuretics up front. This is a disease that is very volume and blood pressure dependent. And if you can really get the blood pressure down and diurese them, the mitral and tricuspid regurgitation can become less. So that is first-line therapy for sure. And if those therapies then fail, then we have other things to do. Mitral valve repair can be done surgically or mitral valve replacement. Again, we're trying to watch and see, is the squeeze of the heart going down? Is the ventricle dilating? What kind of symptoms do the patients have? Remember that the class 1 indication is actually for mitral valve repair. But if you look at the number of patients who get repair versus replacement in the United States, it's not very many. There are not that many great surgeons that do mitral valve repair and end up replacing the valves, which is not the class 1 indication. Right? So We're watching the ejection fraction. We have these mitral clip or Pascal devices that Edwards has as well to try and clip the anterior and posterior leaflets together to reduce the amount of leak that patients have. And these things are now readily available, and a lot of these procedures now can be done in 20, 30 minutes. It's unbelievable. The clip technology has changed. You can take a patient, here's a 90-year-old patient that has significant mitral regurgitation, and you have a couple of clips on there, and they do well. And this was early on, 90-year-old, just over an hour, but now these procedures can be done very quickly. And there's still enough room in there to get blood flow in. Complication rates are very low, especially in the highest risk group of patients, but in a lower risk group of patients, they're even better. 3-year data, 5-year data. We can put valves inside of mitral annular calcium, and we should probably get a calcium score on that mitral valve maybe, probably over 100. We have ways we can put valves in. I'll only talk for another few seconds. We can put valves in the mitral position. We can put valves in the tricuspid position. We have lots of ways now that we can deploy actual valves, so valve replacement instead of valve repair. So we can do things in the tricuspid position, remembering that the tricuspid valve, the vast majority of times, is not tricuspid. It's got 3, 4, 5 or more leaflets on it, but we have ways in which we can put clips on there as well. So you can take patients from torrential and horrid tricuspid regurg to now being treated. So, and there's valve replacement in the tricuspid position as well. And Edwards has what we call the evoke valve that you can put in there and help replace things in the tricuspid position. So we could markedly treat all these patients with valvular heart disease in every position. And thank you for listening.
We had a patient in the office not too long ago where several of the medical assistants were asking one another to take the patient's blood pressure because his blood pressure was 130/20s. And they wouldn't believe it, but the patient had severe aortic insufficiency. Young guy in his 40s, a mechanic, couldn't function.
Yeah, it's unbelievable. And the thing is, because the valvular heart disease happens in a slow, progressive way, until you get to that end stage, a lot of patients don't have symptoms. By the time we see those patients, there's already so much damage that's been done to the heart, you wish you would have diagnosed them or figured it out earlier. But it's unbelievable. And in the cath lab, we can watch the pressures from the aorta come all the way down till it meets what we call the left ventricular end diastolic pressure when that valve is wide open. It's unbelievable. Yeah. Yeah.
Repeat the question.
So younger patients we're seeing younger patients with valvular heart disease, right? And should we be doing screening earlier on? I think as practitioners, I first off say that you have so much on your plate that it's unbelievable, right? People I get to specialize and focus on things in cardiology, but there's so many things that you have to care for and know about in treating your patients in the office. It's very hard. I tell people to listen with the intent to hear. Just because it doesn't say aortic stenosis, mitral regurg on the chart doesn't mean they don't have it. So listen with the intent to hear every time you put the stethoscope on the chest. If you hear something, get an echo. Just get the echo. It's an ultrasound-based thing, but the initial pickup is either the patient has symptoms or I hear something on my exam. So the exam still has to be there for us to initiate that echo, because if not, there's no other great way to pick it up until patients have symptoms. There is no mandatory screening in the guidelines right now to say every patient over the age of 35 should have an echo. Those guidelines don't exist. So it'll be based on your suspicion, any family history of maybe bicuspid or valvular heart disease, dilated aortas, or something you pick up on exam. But there's no dedicated screening right now for younger patients.
Let me emphasize the word Dr. Southard used on the intent. Which means when you put your stethoscope on the chest, tell yourself, I want to hear a murmur. Because I tell you, I've received referrals for a cardiac murmur, and when I listened to the patient initially, I really didn't appreciate it, but when I listened carefully with the intent that this patient was referred for a murmur, and I listened carefully, you'll find it. So that intent means tell yourself, I want to hear if this patient has a murmur.
Yeah, convince yourself you can't hear it. Yeah. Yes. Your mic has insufficiency.
Yeah. Once, once the tower is placed in, what is the timeline for patients to remodel? Do they remodel? Because I see a lot of patients in my office that have come in, they had a tower and I'm still short of breath, still short of breath. Obviously, they come in to see the lungs of the problem, and a lot of those people were never smokers.
Yeah.
And I tell them, well, I explain my own limited cardiology knowledge. The heart takes a while to remodel. You had a heart that was really dilated. It basically became a big muscle. There's no place for the heart to go, so it has to grow inward.
Yeah.
So it takes a long time. But what is more or less what can I tell patients? Say, well, in 3, 4, 5, 6 months, a year, you're going to notice.
Yeah, remodeling, that's a very good question. So what I tell the families and patients, if we just deal with aortic stenosis and then aortic regurgitation, right? So if we pick the TAVR patients right now who have aortic stenosis, I tell the patients and family, I said, listen, if I gave you 10-pound weights or 15-pound weights and I had you do curls continuously for decades, your biceps are going to get really big. And the day I set the weights down, your biceps don't go away. You still have very thick muscle. And that's the way we think of the left ventricle. It becomes very thick, hypertrophied, they have diastolic dysfunction. And I said, you'll feel better immediately because we alleviated the obstruction, but we have to have good blood pressure control now. And over the next 3 to 6 months, how are you going to feel? And when we do our 1-year follow-up phone calls on our patients, we see them all at 30 days. They see their cardiologist after that. We call them all and talk to them or meet them in the office at 1 year. The patients at 1 year feel far better than they did even at 30 days. And they feel so good, they can't even imagine how bad they actually felt when they get to that 1-year mark. When we get a lot of that left ventricular hypertrophy, the walls can actually shrink back down. They're not 14, 15 again, they're down to 12, hit to 11. It can actually remodel. Things that get too old or too far along, and the older we are, it's harder, and a lot of times we have to look for other things that are making them short of breath. But in the first 30 days, they feel better. And then if we get them to that 6-month or a year mark, they feel even better with good medical therapy. Don't ask me a tough question, Brandon. I'm not very good. Just a junior college guy up here. Oh, yeah. Yeah, yeah.
But in a patient who has ejection fraction of 40%, who has a valve area of 1, but the gradient and the velocities are not there.
Yeah.
The criteria.
Yeah.
They're short of breath, but is that heart failure or is that the aortic valve?
No, that is a great question. So Brandon's question is really if the squeeze of the heart is not normal, they have systolic dysfunction, not 10%, but their EF is 40% maybe, not the normal 55 to 70%, and the valve doesn't open very well. Maybe the valve area is around 1, but the velocities are not very high, the gradients aren't very high. What do? Do I replace the valve? Do I treat the patient's heart failure? And these are, I think, the hardest patients and the patients we want to see even more, because I think as a group, and we make a decision in clinic to say, listen, the valve is at least bad enough, we think replacing it makes sense. And we don't worry about, sometimes you can give those patients dobutamine to try and get the heart to squeeze better and see if the velocities go up, or does the valve start to open better? If we give them dobutamine and the valve opens better, it's the heart failure we have to treat and not the valve. If you give them dobutamine and the valve doesn't open, the velocities increase, we got to treat the valve first and then the ventricle second. Yeah, so we can do different techniques and things, so.
All right, go ahead. We'll make it the last question.
Yeah. That's a great question. All of our initial trials were done with aspirin and Plavix. Secondary trials were done with aspirin alone. The current strategy in patients is aspirin. So they just need aspirin lifelong, 81 milligrams of aspirin a day. I still think there'll be a time where in low-risk patients, we might put them on anticoagulation aspirin warfarin, which is the current surgical guidelines for the first 3 months as things heal. And in patients with low risk of bleeding, maybe we have them on Eliquis or something longer, but we're still doing all these other trials to figure out exactly what to do. But right now, they just need 81 of aspirin. Yeah. Thank you. Thank you.